back to our MemoMap. Today we are exploring the cardiac muscles, and we will start with an all organization of cardiac muscle, then understand the functional rule of the atrium and ventricle, and after that we will simplify how the cardiac muscle contract, and finally we will talk about the cardiac action potential. So let's make it clear, simple, and easy to remember. Let's begin with the general organization of the heart. Structurally, the heart is divided to atrium and ventricle. Each has a right and left side. The atrium communicate with the ventricle through the AV valve. From the histological point of view, the cardiac tissue has three types of cells: the contractile cell, the excitatory, and the conductive cell. The contractile cardiac muscle is striated and it's made of actin, myosin, which are arranged in sarcomere. The conductive system is the SA node, AV node, AV bundle, Purkinje fiber. The cardiac muscle has a unique property since it is automatic, rhythmic, self-excitable, able to conduct the impulses due to the gap junction. So it acts or function as a syncytium. That's to say, the atrium contract together as a one unit, the ventricle contract together as a one unit. Let's now move to the function of the atrium and the ventricle. The atrium contract first, then the ventricle follow the atrium, and they do not contract at the same time. The atria act as a pumping that push the blood to the ventricle, so the contraction is a little bit weaker. While the ventricle generates a stronger contraction, since the right ventricle needs to push the blood to the lung, the left ventricle pumps the blood to the systematic circulation. Now let's move to the mechanism of the cardiac muscles contraction. First, we talk about the excitation-contraction coupling. Action potential travel along the membrane TTPU, similar to the skeletal muscles, and this will open the L-type calcium channel, allow the calcium to enter from the extracellular fluid. Well, the incoming calcium will trigger the more calcium release from the sarcoplasmics, and this occurs through the ryanodine receptors. This is to say, calcium-induced calcium release, calcium from outside induced calcium releasing from the sarcoplasmic reticulum. The increased calcium will bind to the troponin, also similar to the skeletal muscle, allow the actin and myosin cross-bridge and the contraction occur. For relaxation, the calcium must be removed, so either pumped back to sarcoplasmic by Cerca pump or transported out of the cell by sodium-calcium exchange. So, always remember that in cardiac muscle, the main source for the calcium is extracellular, not the sarcoplasmic reticulum. Let's talk about the action potential. First, the ventricular muscles action potential. The resting membrane value is minus 85 to minus 90, while in the action potential, the peak reached to positive 20. The shape is a spike followed by the plateau. Let's now talk about the molecular mechanism for each phase. We have 5 phases, 0, 1, 2, 3, and 4. Regarding phase 0 is the rapid depolarization caused by voltage gate sodium channels, so sodium N. Phase 1 is a brief initial repolarization with a transient potassium efflux, while phase 2 is a plateau phase. Here the potassium stops and the calcium start. The calcium channel open and allow the influxes of the calcium. Remember, the plateau is important because 1, it prolongs the contraction. 2, it is prevent the tetanic contraction. 3, it maintains the rhythmic pumping. The third phase is the rapid repolarization. Here, the calcium channel close and the potassium efflux start. And finally, phase 4, which is a true resting membrane potential. The potential return back to the minus 85 or minus 90 by potassium leak and sodium potassium pump. Okay, so during the plateau, there is an absolute refractory period, means no action potential can occur, and this ensures rhythmic contraction and prevent the tetanic contraction. Also, we have a relative refractory period follows the absolute, where stronger stimuli is required to cause an action potential. Now let's talk about the pacemaker's action potential, which is generated in the SA node, and the SA node is located in the right atrium, and it acts as a spontaneous generator of the impulses that regulating the heart rate. Structurally, it contains a very few contractile elements and has no true resting membrane potential. Rather, the membrane potential is around minus 55 to 60 millivolt. Why is it less negative? Because of the slow inward of sodium leak and calcium leak, and this is caused the funny current, which gradually reduce the negative inside the cell. In the SA node, we do not have a stable resting membrane potential, rather we have a slow spontaneous depolarization caused by the funny current. And then uh, we reach to the when we reach to the threshold level, which is the minus 40 millivolt, the calcium channels open. The L-type calcium channel allow the influx and the depolarizations. And the fast, remember that the fast sodium channels is inactive when the polarizing is minus 55. That's to say the action potential here or the depolarization is dependent on calcium and not sodium in the SA node. The upstroke is slower also when we compare it to the ventricular muscles depolarization. As for repolarization, it occurs when the calcium close and potassium open, and it returns back the membrane potential to minus 60 millivolt, where the funny current restarted the slow depolarization and creating the rhythmic firing. Finally, let's compare briefly the ventricular and the SE node action potential. So with the ventricular, the resting potential is around minus 85 to minus 90. So it's true resting membrane potential. Fast sodium dependent repolarization. Plateau is present, caused by calcium. No automaticity, and the threshold is around minus 70 millivolt. Meanwhile, the SA node, the potential is around minus 55 to minus 60. There is no true resting membrane potential. Slow calcium depolarization, not sodium. No plateau, automaticity, and self-excitable existed, and the threshold is around the minus 40. Before we leave the cardiac muscle, let's quickly review the impulse conduction. The impulse started by SA node, then it spread to the AV node where an important delay occurs. This delay allows the atrium to finish the emptying of the blood into the ventricle before the ventricle contractions begin. While is the conduction slow in the AV node because the AV node has a few gap junction. From AV nodes, the impulse passes to the AV bundle and then to Purkinje fiber, were rapidly distributed all through the ventricle. Let's now move to the ECG or the electrocardiogram. First, to understand the difference between the monophase and biphase recording, the monophase recording measures the potential change inside the single cell, so it is an intracellular recording. Biphasing recording, like the ACG, measures the potential difference between the two electrodes applied on the cardiac muscle, so it is an extracellular potential measurement. In the biphasic record, no deflection recorded when the tissue is completely depolarized or repolarized. A wave or deflection appear only during the partial depolarized or repolarized. So if the depolarized move towards the positive electrode, the deflection is positive. If it move away, the deflection is negative. Now the type of ECG leads. We have first the bipolar lead, lamp lead. It is classified into lead 1, lead 2, and lead 3. Lead 1, the right arm electrode negative, left arm positive. Lead 2, the right arm electrode negative, the left leg positive. Lead 3, the left arm negative while the left leg is positive. Remember also the Einthoven law. The Einthoven law stated that lead 2 equal potential equal lead 1 plus lead 3 potential. Now the second type is the unipolar lead. Here we measure the electrical potential between the one exploring electrode relative to an indifferent electrode, and it's classified into augmented limb lead and precordial chest lead. The augmented limb lead are AVR, AVL, AVF, and the positive electrode is on the one limb, and the indifferent electrode is formed by the combine of the other limb. The precordial chest lead is from V1 to V6. The positive electrode is placed on the chest and indifferent in the central terminal part of the three limb lead. Now the ECG waves and the interval. The P wave represents the atrial depolarization, the QRS, the ventricular depolarization, the T is the ventricular repolarization. You may ask, where is the atrial repolarization? Well, the atrial repolarization is not seen because it's masked by the QRS complex. The most important interval is the PR interval. It starts with the begin of the P and end with the begin of the QRS, and it represents the conduction from the atrium through the AV node to the ventricle. Finally, remember that localized damage may appear in one specific lead because the lead view a heart from different angle, but the arrhythmia usually appear in all lead because the rhythm disturbances affect the entire heart. And that brings us to the end of today's MemoMap on the cardiac cycle. Let's quickly recap. We started with the general organization of the heart, to atrium, to ventricle, right and left, physiologically cardiac muscles, contractile cell, and the automated or the rhythmic cells, and the conductive cells, and the cardiac muscle is striated and containing the sarcomere, and myosin. And functionally, we talked about that the atrium pumps the blood to the ventricle, the right ventricle pumps the blood to lung, and the left to the systemic circulation. Then we discussed the excitation-contraction coupling, that the action potential cause the calcium to entry, this triggers the calcium release from sarcoplasmic reticulum. The calcium allows the actin, myosin, and cross-bridging. For relaxation, calcium is removed, either pumping back to the sarcoplasmic reticulum or move out to the cell. Then we compare the potential between the ventricle muscle and the pacemaker. The ventricle muscle fast sodium-dependent upstroke with plateau, while the pacemaker there is no true resting membrane, no plateau, slow calcium-dependent depolarization, and repolarization in both occur through the potassium effluxes, and the pacemaker is characterized by the funny current. Then we talked about the conductive system, which is starting by SA node, AV node, the bundle, and the Purkinje fiber. Finally, we covered the ECG, that the leads either unipolar or bipolar, and the recorded waves are P wave, QRS, T waves, and the VR interval. That's the complete pictures for the cardiac muscle structure, function, and electrical activity and recording. See you next episode.